I hope that you had a chance to read this article so that we can review not only the article, but where do we go from here? Because we always say, oh, well, you know, the research says, or what does the research say? Well, here it is on Ryan's Law. Here is the first published research about implementation. So moving forward, one of the things we always hear from legislators is, well, how is it working? We're going to wait until we know how it works out. Well, hey, it's working out. So this article is like big time for our advocacy. And so this month here at CNN, our theme for the month is cannabis nursing advocacy. When I reviewed it, there's three main points that I think this article makes. The first is, here is how you develop the institutional policies and nursing workflow, right? So it establishes that can be done. The second thing is it gives a case study. So we have a real life example of somebody who received benefit from having access through Ryan's Law. And then third is the nursing satisfaction survey, where nurses said, yeah, we can do this, no problemo, right? And so those are the three areas that I see in this article that are most important. So open it up. What did you guys think about this when you read it?
Yeah, about time, right? And why isn't it everywhere already? But just really grateful that California's taken the lead here.
I'm so excited that this is the topic. So in Maryland, I was working a lot on what was Ryan's Law, but ended up not being put in as a bill called Ryan's Law. It's a little political, but essentially a bill very similar and based off of Ryan's Law for Maryland legislature. And we had support from all sides, every representation. They were really supportive. And we were even saying, for anyone with a medical card, not even hospice, palliative care. And we never got to a vote. Then after the session, I worked with the Maryland Hospital Association saying, you know, we're just going to put the bill back in next year. Like, they were our only people. They were pushing back and they're saying it's not safe. And I was like, well, like, what can we do to get you on board? Because we're just going to keep fighting. Like, people need this. And we were able to offline write a policy. So not a bill, but like a policy that the stakeholders of the hospital administration for the state of Maryland approved for allowing bring your own cannabis for any medical patient, not even as narrow. Maryland doesn't have a definition of terminal in our law, so that was an issue. Even so that was wonderful. And just like Heather said, the first thing is, okay, who's done it? And I'm like, well, California. And they're like, okay, who's doing it? I'm like, oh, well, no, they passed a bill. So to have a research article, to have an actual implementation, to have something to show, I think is really important. It has been used, implemented, and is documented, and that it is the patient's family or the patient acquires the cannabis, that it's self-administered or caregiver administered, that it's in the room, stored and locked and safe, like all of those pieces that are so important. Brightview is in 8 states on like the East Coast, and we're working to implement cannabis for adult use and medical use in all of their hundreds of facilities. Everything started with Ryan's Law. That's why we're here. So it's really exciting. And I haven't shared this yet. I'm waiting. We have a meeting in 2 weeks, this Brightview Leadership Committee. And I can't wait to like review and share this with them and talk to them about it and just kind of even more sort of assuage their fears. Like, look, somebody did it.
You know what I love about this article? First of all, I just want to give a shout out to the 5 nurses who actually wrote this article and did this research. You know, Amanda, Alyssa, Allegra, Reina, and Maria. So it was 5 nurses that wrote this article. And let me tell you, they did not pussyfoot around. Mm-hmm. They didn't say, oh, well, maybe, I don't know. No, they were like very clear cut. this works for this patient group, which this is clearly it's on the oncology unit, so it's cancer, but it works for this patient group, and it was easy enough to implement, and we haven't had any problems with it. Granted, we've only had 8 patients utilize the program. So that was one of the things that I was like, nuts. I would have loved to have seen 800 patients. But hey, we got to start somewhere. The other part that I thought that was interesting about the fact it was only 8 patients also goes to show, listen, this isn't something that is going to be running rampant in your hospitals and you're going to have to worry about. This is the select few patients that are using cannabis at home successfully and prefer it over the pharmaceuticals when they're in the hospital. So I thought that was kind of like the double-edged sword of like, I wish there would have been more patients utilizing, but it also goes to show that not everybody is going to be wanting or asking.
That's a really good point, because the Maryland Hospital Association, when the stakeholders approved it and we had the policy, I was like, okay, let's shout it from the rooftops. And they're like, no, what if everyone starts using it at once and we're overwhelmed? I'm like, that won't happen.
Well, I love that nurses were involved in this, because so many times we see that the nurses just like, okay, whatever, step back, let the family do it. Families are trying to hide it and pretend that it's a vitamin. So I thought that was really good to see that there actually are nurses that are stepping up and being involved. And that's when other nurses are going to start feeling more comfortable. And I know Marcy can probably talk about this more than I can from that perspective. But watching the patient suffer and then be to the point that they can't communicate or be involved with their families at the end is not a pleasant place. And that's not what we want. And so seeing that there are nurses that are seeing the benefit of that is really important. The other piece of that is we will start seeing more and more people utilizing it at end of life. Because like for me, and I'm so thankful for what Maryland's doing, because if I go in the hospital today, I don't have access to my medicine, which is my medicine and it's what's keeping me alive. So I go into the hospital at a disadvantage and then trying to recover the whole time I'm there and when I get out. The last thing I want is for my family fighting for me at end of life to have access so that I can still participate and be involved with my family. So I think that every little step we make forward is important. That's why I'll be covering this for the newsletter in July and writing an article about it and getting it out, because this just doesn't matter in the US. This matters worldwide as far as I'm concerned, because no patient or loved one wants to be deprived of having that access to their family at the end of life. So you want to have as much access as you can.
Thank you. It's the University of California, Los Angeles, Santa Monica Medical Center. So this is UCLA. First of all, it says the interprofessional team closely monitored patient experiences through a combination of real-time observations and follow-up debriefings. Nursing documentation in the electronic health record system track patient cannabis self-administration. Regular debriefing sessions were also used to discuss patient experiences and gather feedback. These conversations were integral in continually reviewing the process and ensuring patient safety standards were met. This work culminated in a development of the institutional policy outlining the safe inpatient use of oral and topical cannabis for terminally ill patients. So super cool that they brought together a group of not only nurses, it was nurses, medical providers, pharmacists, regulatory affairs, informatics, and executive leadership. And they met over a course of several months to develop a process that would adhere to Ryan's Law. It's interesting because when we were advocating for this here in California, I testified in front of the health committees. I mean, all along the way, every place we had to go. But I kept saying, look, nurses are capable of assessing and documenting, and that's all that we're going to be doing here with this. And to your point, both Laura and Debbie, about having the focus of Ryan's Law being narrow to terminally ill patients versus anybody, we did that purposefully because we were able to vet out every single opposition. And in California, we were able to pass this unanimously. And they're even one of our biggest opponents, that's just a huge cannabis opponent to begin with. He got up and he said, I know you probably are all very shocked that I'm supporting this bill, but Ryan's Law doesn't have much to do with cannabis. What it has to do with is quality of life at the end of life, and I support that. And so there's reasons why we try to keep it narrow, and we're working right now in Kentucky, and we spoke with the legislators in Kentucky, and they were saying, well, the activists are going to be coming out and wanting to expand who else can have access, and they're going to want to add more medical conditions to the list, and they're going to want to do this and do that. And we said, look, we know that, that's what they're going to do, but we have to keep Ryan's Law so that it can pass clean. It's a clean shot. It's like the arrow to the heart, ping. It gets it done. And then the activists can come in if they want to expand the law or do whatever else they want to do, that's fine. But we've said from day one, Ryan's Law was a giant leap into cannabis access and healthcare. This is where we start to marry that. And so excited to see. You can tell I'm a little excited about this article. I'm like, yay!
And we all agree that it should be used for all of these things, but if, like you said, this goes straight to the heart. And who doesn't? If you don't agree that somebody dying deserves to have whatever brings them comfort, then you're probably a bad person. You deserve to have those things that bring you comfort and peace. And too many times, over the past 2 decades, and just watching people have access to nothing and people have access to cannabis in the 2 separate places, when they had nothing else, even there, it wasn't legal. I had patients that had access to cannabis, but it wasn't legal, and I certainly didn't want to know anything about it, but I smelled it. And left it at that. But yeah, it's huge. And I recall being at, the Denver hospice and seeing, transferring patients in to their inpatient care center who were having symptoms that could not be managed. However, the symptom may have been pain, but they weren't vomiting at least because they were using cannabis. Sometimes it's a double-edged sword and they need both things. So when we'd send somebody inpatient for whatever symptom we weren't getting managed, and then they would have to stop their cannabis, it was always like, now we're just going tumbling into more problems before we can scale back and fix what we were trying to fix. And a lot of times the inpatient hospice, those nurses were just like, just do what you're doing. Even if it was vaping, go out on your patio. But edibles and tinctures and patches and all of that was never a problem. It was, you can do that on your own, but we weren't documenting it. And now it's being documented.
That's where the biggest advantage is, I think, is that it's being documented. That's the problem we have with most cannabis use in general medically, but I think at end of life, being able to document that we're actually providing that comfort and that ease at the end of life, and that it's a place where you can enjoy to the best of your ability with your family at the end of life. Who doesn't want that memory and those moments?
Well, and I've been documenting, I will say, at least the last 10 years. I've put that in my notes when I've walked in and found someone using whatever they're using it for. I started putting it in their med list.
So are you still working, Marcy, in hospice care?
I'm not in hospice anymore, not since the end of February.
Oh, really recently? Congratulations.
Yes, after 19 years in hospice.
Well, because what I was going to ask is, it's hard not for me to then think about like psychedelics and end of life, and are we documenting that as well, and how receptive is hospice to that?
They weren't very, very open. It depends on the doctor. That's the medical director. And I mean, nobody's going to be bringing it to the patients. I don't even think ketamine at this point, they're going to be Maybe the Denver hospice has started doing that. Erica, do you know anything? Have you talked to them? They did.
Chris and Darren have done so many presentations to the different hospices. Some of them are open and at least referring people. So I think that's the biggest thing, is to at least have resources for people to be referred to. Outside of that, Colorado is going to be an interesting niche as far as psilocybin is concerned, since we do have that legalized, and now we've got our healing centers that are licensed, and finally have a mushroom grower that is licensed. So these things will make it more palatable to have these licensed, regulated areas. So I think within the next year, it'll be interesting to see kind of how much that opens up and how much people are paying attention that are interested. So, but even getting ketamine in is, as you know, Marcy, just damn near impossible. These are baby steps that thinking cannabis has a stigma, the psychedelics, misunderstanding of what we're talking about with psychedelics and end of life is we're not taking them out on a trip on their last breath. This is when people are able to come into this, able to participate, still at a point where they are able to integrate, because you have to have that time to integrate. And if we are really discombobulating somebody, there's not a lot of time for reassembling. So we have to be cautious with that with people too. So there's a lot in the psychedelics and end of life. And I think, and I've mentioned this before, I get more people interested in cannabis through talking about psychedelics than I ever have vice versa. So it'll be more, because you can talk to them about the options and how much kinder and gentler cannabis is for that. If they just need to get out of their head and be able to have an altered state and be able to soften, then cannabis is a beautiful start for that. And then ketamine, and then psilocybin.
Well, it's almost like it's this circle here too, that a lot of people get into this space where they are discombobulated and maybe even out of their head within combination of what's going on in their head at the end of life. But I feel like psychedelics also have a way, any different varieties of whichever they choose to do, has a way that allows them to process all of those thoughts that they're having, so that they may not need quite as many every 4-hour Ativan or Xanax.
Absolutely.
And then their head is clearer.
The emotional distress that comes along with that, you cannot medicate away.
No, you can't.
At least not with an opiate. Let me clarify, because I think there are ways to alter that with these plant medicines, but you are not going to get there with the opiates. So if we can ease that existential distress, then that is where the softening and easing into the rest of it can be.
Even the benzos, benzos are great, but my personal experience with benzos was like, okay, my anxiety is reduced, but what I found over time is also my coping ability was reduced.
Your responsiveness, you may not have anxiety, but you don't have a lot of love, you don't have a lot of anger, you don't have a lot of sadness, you have a lot of flatness.
And then rebound anxiety if you don't keep taking it. I see that with a lot of my patients.
And at the end of life, it's not so much, I think, for family members that are trying to deal with coming to terms with losing someone they love. If those family members are taking these anti-anxiolytic medications, the thing that's really sad is it takes your memories from you, and you are going to be left without being able to remember the passing of your loved one, because you were so anxious you couldn't be there without taking this pill that was making you not be there.
The good things about this research also is that at least we have something to put in the hands of someone else in another state, even if we're going into a hospice or end of life care, to say this is research that's been done, and can you look at it and can we have a conversation? My loved one uses cannabis, and can we continue it based off of this?
And I think that's where the case study comes in too, right? Because when we're advocating for things, it always comes down to the storytelling. They listen to the storytelling. And so I was happy that they did a case study. But let's talk about the case study, shall we? KM was a female aged 53. She had come in to the oncology unit for scheduled inpatient chemotherapy treatments, and they deemed that her condition was terminal, and they offered her this treatment for palliation and potential life extended benefits. It says that she experienced nausea, pain, and anxiety secondary to her diagnosis and chemotherapy treatments, and took medical cannabis as part of her at-home regimen for symptom management. On admission, the provider determined that she was eligible for the compassionate access to medical cannabis under Ryan's Law, and the provider placed the order to approve her self-administration. So the provider ordered her self-administration of medical cannabis after reviewing her medical cannabis identification card and completing the medical cannabis patient consent form. This form requires the patient's signature as an agreement that the patient is exclusively responsible for the ordering, delivery, self-administration, storage, and disposal of their medical cannabis. Once the clinician placed the order, nursing staff contacted the pharmacy for delivery of the medical cannabis lockbox and education for setting her own personalized code to access and store her supply. So they're telling us through this case study how the workflow goes. During the course of 6 months, she received 6 cycles of cancer treatment. The team reviewed and obtained eligibility and patient liability on each subsequent admission. So every time she came in, she had to sign the consent form. KM typically self-administered oral cannabis once per day and notified the staff each time she self-administered. So they don't even, the nurse doesn't even have to sit there and watch you. You basically say, here, whenever you pull it out and use it, let me know. Okay. KM mainly self-administered to manage her pain, anxiety, and nausea, and the staff nurse documented each instance of use on the medication administration record as, quote, administered by patient. KM found the lockbox easily accessible and expressed satisfaction with the security of the lockbox and the ability to continue her home regimen for symptom management while admitted. She stated medical cannabis was most effective for managing her pain levels, which allowed her to be comfortable without being overly sedated. So I just think that's really wonderful that they were able to do that. And then the end part of this was, then they sent out this nursing satisfaction survey and asked the nurses what they thought about it. So the prompt, I feel comfortable implementing Ryan's Law into my practice. Only one person said they didn't feel comfortable. Everybody else either agreed or strongly agreed or whatever, I'll do whatever you say, right? The majority agreed strongly. Let's see. The second prompt, I feel that Ryan's Law helped my patients with their symptoms on reassessment. Everybody agreed or was neutral. Nobody disagreed. So clearly it was helping. And then the fourth one, I feel that Ryan's Law had a positive effect on my patients' stay. And again, everybody had agreed with that fact. And so that's huge. It's like no problems. It was easy enough. They did talk about limitations. Data are limited by small sample sizes and the experiences of a single institution located in a state that has a law for inpatient medical cannabis use. Despite these limitations, the development of the institutional policy and nursing satisfaction with its implementation demonstrates how healthcare policy can be successfully translated into clinical practice.
And I think that one of the things I picked out of that is that at the very beginning, they talked about the person having their medical cannabis prescribed prescription, whatever. And I think that's something that we all need to think about, because as adult use becomes more and more available, people are walking away from getting their card or keeping their card. And I wonder how they would have looked at that if they didn't have that card.
Patients self-administered medical cannabis to manage the following symptoms. And out of the 8 patients, 6 of the 8 patients used it for anxiety. 6 of the 8 patients used it for sleep. So sleep and anxiety were the highest numbers. And then 3 used it for nausea. 2 used it for pain. Clearly KM was one of the 2. And then appetite stimulation was only for 1. What these folks are looking for is sleep and anxiety, number 1 at the top of the list.
Well, that's that existential, stress at the end of life. People don't want to go to sleep because, they're afraid they may die when they are asleep, and certainly they may. And it reminds me too of this veteran I had, who, the poor guy, he must not have slept for a whole week. And he didn't want to take his pain meds. He didn't want, he had been a POW as well. So he did not want to take anything that was going to make him feel like he was not in control. And I was able to talk to him and start talking about different products. And he did. He was able to rest. He was able to get comfortable. But, had they just said, okay, go inpatient and let's try to figure out what is going to be a good treatment protocol for you, they would have knocked him out, because they would have had to knock him out. Because if he was just a little bit not out, he would have been freaked out because of the state of mind he would have been in. And so being able to help guide him and his wife along that road to say, I get it. I understand why you don't want to take these meds that the doctors are trying to give you. Clearly, this is not the answer for you. And, that's patient-centered care. This man could not get the standard pharmaceutical comfort kit and be okay.
Yeah. What a blessing that you were there. One more thing that I wanted to bring up, Heather, that you pointed out, but I just want to circle back to it, is the team. So you shared that in the article, it was nurses and also pharmacists and other clinical team and the informatics department. And that's something that in Maryland, and then with this Brightview Assisted Living, in order to work with them to implement this policy in their facilities, I had to ask for them to create a committee that has a leader in pharmacy and a leader in informatics and a leader in administration and one of the nurse leaders. Like, we needed to have across their whole organization leadership, so we could have engagement from all those places, so they can each talk about what the concerns are. Because even if you get the lead pharmacist on board, if their IT system doesn't allow you to enter this into the computer nowadays, since everything is computer, there's a block. If there's no way to drug interaction check, which what I learned from them is, like, the major system that they use didn't have THC as something they could enter. And so then their point of contact is lobbying with that company to get them to add it. But that has to happen before we can. So, like, these are things that, like, we might, as clinicians coming from just the nursing and want to take care of the patient and the family, not think of. But I'm so glad that they pointed that out in the article. And I just want to reiterate how important it is, if you're working with any agency, company trying to do this, that it's really important to ask for a committee or a group to work with to implement it and get all of them on board before you start trying to actually do it.
We just put out a video from Gloria Smith, and she was talking about how you get cannabis listed into the electronic health record as well, so that we can document appropriately. And she talked also about the blocks, that just to kind of, to your point about the technology piece, the blocks that are there on words like cannabis, marijuana, and you try to look up information, and she says, how are we supposed to get the information that we need to make sure that the patient is taken care of, if we can't even do it through our work computer. And she said, if I do it through my phone or something else, it's like a go around of the block, then I'm running the risk of not getting the information from a reliable source. So we need the technology piece of healthcare to get on board. And as you were saying, Laura, really make sure that those roadblocks technology wise aren't there so that we can document what is happening.
Yeah, because doing it just as patient's own med, like free text, I mean, it's good. It's getting it in the system, but it's not, particularly from the pharmacist perspective, the drug interaction checking piece is really important. So
I find it interesting that you were talking, and I think this is an important part as well, talking about getting to where we can enter cannabis into the system. But right now, today, you can enter cannabis use disorder.
Oh, of course.
So, it's like we have.
And that's the button they click. That's the button they click when you say you use cannabis. Oh, cannabis?
Right.
Cannabis use disorder.
So cannabis does exist in there. It's just how they decided they want to use it.
Point. Anything else that popped out to you, ladies, that was exciting or new or problematic?
We just need more of it. That's what we need.
Yeah.
We just need more people willing to talk about it, willing to share it. I think that the more hands we put this research in, and that people see that it does exist and it can make benefit, especially within the nursing industry, because like Nick is always reminding us, how many nurses just don't even want to have this conversation. And this is one of the things that I think could at least start breaking that barrier. Oh, though it might be okay at this point. I'm okay with us starting there.
Yeah, you got to wonder who is that one person that said they weren't comfortable in line?
Right.
And could some education help get them there, or is that their stigma that's so
thick?
Yeah.
Thick.
Thick is a good word for it.
well, and I just find it kind of inspiring, just thinking about like all the experience we have working with patients, at all different parts with cannabis, and I might think about writing a book, but to think about like putting it and calling it research and putting it out there as research, as Heather and I are on this University of Miami task force, and that's one of the things is there's not a lot of nurse-led research, and then particularly nurse-led cannabis research that I just think, wow, these 5 nurses were so brave to, and that's inspiring just to think, no, don't just write an article. Like, get it published as research, do the work to make it research so it gets more credibility than just another story. So that's just something that's now I'm like, need to do better.
Yeah. And it was really, like you said, the teams, it was that they would come together, they would do debriefing, they would use the debriefing from after you had a cannabis patient. How did that go? What did you see? They gathered all that information, and then was able to analyze it and create this document. I don't know if you can see this, but there's this big in blue, it says right here, and it says, quote, "This law helps nurses to support patients who choose to use cannabis for relief from pain, nausea, and other treatment-related symptoms." And I thought that was amazing that even in the research article, they did this big old quote in a different color that said, "This law helps nurses help patients." And honestly, that's my payday. You know what I mean? I always say advocacy doesn't pay. You don't get monetary value ever from being an advocate. But when you've spent, like we helped Ryan in 2018, we helped Jim and his family. When Jim came to Ken and said, "I want to write this law, I want to do this," he was grieving. This is his way of post-traumatic growth and grieving, because the loss of his son is to make this a reality. And that was 18, 19. We're here in 2025. And you can read in a research article that this law helps nurses to support patients who choose to use cannabis. And I say, that's why we're doing what we're doing. I don't care how long it takes, how much we have to fight, how much we have to stand up. Every step forward is a step forward. And it's a good day to be a cannabis nurse with this research article, and a good day to be here with all of you. Thank you for taking an hour out of your day to be here and spend some time to look at this research article. It means a lot to me, and hopefully it means a lot to you as well.
Definitely means a lot to me. I can tell you that, working in oncology, and would have loved to have seen this available many, many years ago.
Makes me want to make a bunch of copies and go drop it off at the different hospitals, oncology units, and hospices. And
Do you have contact information for any of those nurses? Do you know any of them, Heather?
I don't, but I really wanted to reach out. You know, I would like to send them just a little message from me and from the network, and just say thank you. Thank you for picking it up and moving with it. The fact that they did this, I'm eternally grateful. I love you, ladies. Thank you for being here.